So any questions, any concern that you have, please write on the chat. We will keep the session unmute to everyone for the good function of the session. So a few words on Aptisen. Aptisen is a musculoskeletal company that delivers orthobiological solutions to joint medical specialists like you. We are a Swiss company based in Geneva, and we are mainly distributing our products through distributors. Sorry, we have a technical problem. So we are distributing our products through almost 30 countries worldwide, with 3 affiliates in Italy, France, and Poland. And in other countries, we are working like with MedicWave or Anfatec, your partners in different countries. We deliver 2 type of solutions, so orthobiological solution with our viscous supplement SYNOLIS VA that we will talk about today, and also our OTC product that is a drinkable food supplement based of collagen. So I hope that you will enjoy the session today. I'm really happy that you are all here with us today, and I will let Dr. Vidovic take on with his presentation.
All right, thank you, Elizabeth. Hope everybody here as well. I was intending just to take a few minutes of your time before Dr. Go's intervention is to walk you through a little bit through this very, very unusual development in general concerning the visco-supplementation. I must admit that in 25 years of my career, I have rarely, if ever, seen something like that. So in talking of the days and years in the years 2000, 2005, 2006, I was myself at that time collaborating with Sanofi and launching one of the first visco supplements, which was called Hyaluronic. There was generally a very, very positive result and impact of all of that. The people were, and the acceptance of the method and of the product was excellent, both with orthopedists and rheumatologists. And I just took one example from 2009, where Malveni and his collaborators made a large review and concluded that more than 11 studies suggest that visco-supplementation in the hip already is as effective as visco-supplementation in the knee, that it appears to be a safe and a reasonable alternative to the NSAID drugs or steroids, the intra-articular or oral. And there was a very general wide consensus at that time that the knee visco-supplementation for the osteoarthritis is a good thing. It reduces administration of opioids, which already at that time was raising alert, anti-inflammatory drugs, it improved risk-benefit ratio, and may delay, they say, but indeed there were already results that were strongly suggesting that it delays the joint replacement, and that it delays the general problem with the arthroplasty. And so the situation wanted to be sort of adapted by like a very, very general and well accepted consensus. And then the word controversy stepped in. The review, the famous one, the treatment of the osteoarthritis of the knee by the American Academy of Orthopedic Surgeons in 2013, started raising concern about those treatments and how they relate to the use of viscosupplementation for the osteoarthritis and so on and so forth. The discussion and the controversy started, and I must admit that the what I call the side effect, or the long-lasting side effect of that, is that even now, in the beginning of this year, I was talking with a number of my colleagues, which are the general practitioners, the internists, not necessarily the orthopedic surgeons or the specialists, but there is still a general kind of atmosphere that the issue of the viscosupplementation is somewhat controversial. Now, what that had as a consequence, it had as a consequence much more important side effect, as quite the dire consequences, that there has never been really anything similar that I can recall, except maybe for the exception of one back and forth of the American health authorities, CDC, with respect to the last generation of antihypertensive drugs, anti-blood pressure drugs. But I cannot recall of an example that has been a major payer non-coverage decision in the US for the use of these modalities, for the use of the viscosupplementation. That is, since publication, several commercial insurers, a lot of them, the system of the insurance system in US being quite complex combination between the private and the public health, but nevertheless, a lot of patients were kicked out from the coverage, and they have issued an uncoverage determination. Then in 2015, the similar meta-analysis was published in France. France has a single payer system, like most European countries, and it led to a 2016 de-reimbursement of the treatment for the osteoarthritis. It followed an enormous, very large petition against that non-coverage since it was announced, and was signed by thousands of French doctors and the patients suffering from osteoarthritis at different centers, but with no success. Then, little by little, starting from 2000 people, experts, epidemiologists, physicians, orthopedists, internists, started to look closer into the guidelines and started asking the question, was this method the so-called minimal clinically important improvement that was one of the leading criteria in that review, in that meta-analysis? Was it used correctly? Was it utilized appropriately? Is that asking a very good question? Is can you just put everything in the same bag, or should they have looked at the high molecular weight viscosupplementation and differentiate it from the low molecular weight? But because already at that time the evidence was quite clear that the low molecular weight is less efficient. And the third question is, in the years past after that review has been completed in 2012, had there been more recent results, more recent clinical trials, more recent compelling evidence that should be considered rather than following blindly the evidence? And then what we can call the tide starts slowly turning. So in 2015, there was a large review by Banuru, and Joe Hall, with his collaborators, 2016, suggested bluntly that guidelines, those may provide inaccurate and misinformed recommendations, and that the careful examination of the most recently published articles suggests that viscosupplementation is indeed a safe option with a clinical reduction in pain in those, and especially in those formulations with higher molecular weights. Other trials that I put here, the other articles and meta-analysis that I put here as an example, showed the same thing. At the same time, the European Society for Clinical and Economic Aspects of Osteoporosis, the SCO, concludes that we should definitely include the intra-articular hyaluronic acid as therapeutic option for the management. At that moment in 2018, the American medical policies issued that the VS by intra-articular injections, hyaluronic acid or sodium hyaluronate preparations may be considered a medical necessity for the patients who meet all of the following documented criteria, which we now pretty much all follow and know, that is symptomatic painful osteoarthritis of the knee, osteophytes of the knee are confirmed by reading imaging, functional disorders, problems with walking, standing, or morning stiffness, that the cause of pain clearly is not attributed to any other problem or joint disease, and with the patients who failed to respond to sort of what they call the comprehensive treatment program for 6 months, but basically it's the oral antalgic therapies. And then, as a result, in the US, some insurers started going back and proposing full or partial coverage. And then at the end, there was a little bit of a tendency to drift slowly away from these firm guidelines. So last year, the Euro-Visco consensus group recommended the patients treating with visco supplement, the ones with a mild to moderate knee and hip osteoarthritis. I attract your attention here that it is both knee and hip. And very importantly, they concluded to consider patients' individual characteristics and patient wishes as a key for therapeutic decision making. They added the recommendations for the retreatment, and and collaborators in the title of their review put why we should definitely include intra-articular hyaluronic acid as therapeutic option, and it was an extensive critical literature review. So to conclude, what can we learn from this kind of a, I call it a U-shaped development that happened over the last 10 to 12 years? Well, the first conclusion, if a clinician was strictly adhering to review and guidelines between 2008 and 2018 or 2020, it will appear like riding a roller coaster. They have everything, very confusing, very unclear, and in many cases conflicting. I just put here that we should always mind the prevalence of the disease when anticipating the health authorities' decisions on coverage. 10 to 15% of symptomatic osteoarthritis patients aged under 60 suffer from symptoms, so that is a very, very large population, and the price and the cost of covering it either by single payer or multiple payer insurance companies is something that always has to be considered in these cases. And then what we also conclude is the main place to get informed are through recent, controlled, randomized, comparative studies, the ones which are well-powered and well-organized, and there is more and more of them coming up. So I'll give you one example of such study as my colleagues have introduced, that we have just recently completed a long-term efficacy and safety evaluation of SYNOLIS, which is a sodium hyaluronate, 2% combined with sorbitol, versus the Synvisc 1, which is a reference drug in the market, probably the most prescribed and most used over the last 10 years. It was a double-blind, controlled, randomized non-inferiority parallel group study. Those study results will be presented at the ULR virtual conference on the 4th of June. I hope you will manage also to attend. It will be presented in as a poster. Virtually, it's a non-presential conference due to the reasons we already know. What I'd just like to put in tension when we did study Synolis versus Synolis, that it is interesting to observe that one of the characteristic of Synolis is that it is combined with 4% sorbitol. The choice of that was carefully examined and selected, and I would like to pass the word to my colleague Bernina Nesson, Dr. Nesson, who has been working with the product for already several years, to tell you what was the reason behind choosing the sorbitol as a combined product. Thank you very much.
Thank you, Edouard. So I will take a few minutes to talk about why Aptisen chose sorbitol to design our product. So to obtain optimal rheological properties, our R&D department created a HA-based solution combined with sorbitol. And this sorbitol is here to protect our HA, which is not cross-linking, meaning that it's not modified chemically. And the sorbitol is a polyol, in case, just to clarify, it's a polyol with antioxidant functions. And basically what the sorbitol does is neutralize the free radicals by an electron donation. So after neutralizing the free radicals in the affected ONE, the HA molecule is able to have its proper function in terms of homeostasis in the synovial fluid, and also in terms of rheological properties, stabilize the synovial fluid rheological properties. To see how this synergetic action between the HA and the sorbitol occur in the solutions, and to see how the sorbitol is protecting the HA, our team performed an experimental experiment in vitro to provide an evidence on the strength of sorbitol to protect the HA in the case of accelerating degradation. So the aim of this study that you can see on the screen is to see the resistance of the different type of gels, resistance to free radical degradation. So we compare Synolis VA to other products on the market, and the way they did it is basically they added antioxidant agents, oxygen dioxide, in the test tube with the different viscosupplement products. And then they eat the different solutions for several minutes, and then they see what was the behavior of those different solutions. After 3 hours, you can see that most of the solutions lost their viscosity and elasticity, and only Synolis VA is able to stay at the state where it was before. Meaning that the HA of Synolis VA combined with the sorbitol, at least in vitro, is well protected against free radical degradations. If you want to know more about the sorbitol action in the Synolis VA, you can ask our partner to share with you a document that we have provided, MedNews, about sorbitol. So now I will let Dr. Go to do the presentation on hyaluronic acid injection for shoulder and hip indication with injection techniques. So Dr. Go is it's a physician with who we are working for several years now. He's from Singapore, and is well known and specialized in medicine, and he has a lot to share with us on the injection technique.
Thank you. Excuse me while I get myself sorted out here. Okay, good afternoon, everybody. I see there are 89 people now online, and I understand most of you are from Southeast Asia and from Malaysia, from Indonesia, and some from Vietnam. Some of you may have heard me speak before, some of you know me. So I hope you're all keeping safe wherever you are, in your house or in your office. So my role today is to talk about hyaluronic acid injections, focusing on the techniques, but I find it impossible to divorce the techniques from indications. So I'm going to talk about indications and the respective technique. So to dive right into it, the common things which are injected into the joints are usually, oops, sorry, did my screen just disappear? Hang on a second. Oops, just a second. I can't find my slides all of a sudden.
Dr. Go, we can still see your slides.
Yep. Oh, you can still see it. Oh, okay, now I can see it. I'm sorry about that. Okay, sorry. So the common injectates which are used for musculoskeletal purposes in the knee, we are all familiar with corticosteroids, and then there's hyaluronic acids, and there's PRP, and then there's a whole list of other things which people put into joints and muscles and tendons, and some of these I would say are very peripheral, and they are not really well-proven things. You got tramadol, which is opioid. You got ketorolac, which is an NSAID. And for people who do prolotherapy, you could use dextrose. But by far, the three most common used in conventional medicine are corticosteroids, hyaluronic acid, and PRP. And today, I'm only talking about hyaluronic acid. But I just want to highlight that injection techniques for each of these are a little different because the considerations are all different. But today, our focus is hyaluronic acid. And so most of us use hyaluronic acid. I assume most of you are clinicians, and you would have used hyaluronic acid, and it's usually for osteoarthritis of the knee. So you could say that hyaluronic acid usage for osteoarthritis is almost synonymous with osteoarthritis of the knee. But as Dr. Edward was referring to, there's actually other users in other joints. In fact, it can probably use for any synovial joint. Okay, so just very quickly, the purported mechanism of hyaluronic acid on osteoarthritis. There's direct mechanical protection of the joint through the articular surface, directly, that means you have to get the hyaluronic acid onto the articular surface for this to happen, for direct mechanical protection to happen. And metabolic effects, which include production of HA by the joint cells themselves, by the cartilage, reducing the inflammatory cells in the synovial fluid, and possibly stimulating the proliferation and differentiation of chondrocytes. So in a nutshell, these are the reasons we use hyaluronic acid. Some mechanisms are not fully understood, but in broad terms, these are the reasons for using it. Both of these reasons require direct application of the hyaluronic acid onto the target location. And that's what the injection and the accuracy is all about. So as Dr. Atwood alluded to, you can see if you just sweep through all the various societies which want to have a say about hyaluronic acid, you'll see that quite a number of them, you can say that it's at best lukewarm. You know, some from not recommended to recommended in certain situations. And if we look at a fairly recent systemic review, we'll find that high molecular weight hyaluronic acid has the strongest current evidence for clinically important and significant treatment effects on the knee. Although PRP may have the greatest point estimate, it's not very consistent. So again, Dr. Edward touched on a very important point to try and differentiate between the high and the lower molecular weight. And high molecular weight definition in this paper goes from 1.5 to 6. All right, so it is an important distinction to make. Now, one of the big questions we always ask ourselves as clinicians is how safe it is. And because one of the first rules of medicine is that we must not do harm to our patients. So the safety studies have been quite extensive, and we know that it is safe for patients with knee osteoarthritis. There may be some association with non-serious transient local reactions. And it is actually suspected that a lot of these are due to misplacement of the hyaluronic acid. It might actually not have hit the correct target location. So whatever side effects which occur tend to be non-serious. So I think in a broad sense, we can say it is a safe treatment method. Contrast this with steroids, which tend to be more favorably viewed by most societies, even the AAOS and some of the big societies. We know that steroid shots in the knee and hip will harm joints in osteoarthritis cases. It works fast, but it works only for a short period of time. And so in my own practice, I very, very rarely use steroids into a joint unless I've really no other choice. Now, an important thing when we look at all these guidelines, and if you look at, for example, the NICE guidelines out of the United Kingdom, there's a very important paragraph which a lot of people tend not to read, and it's in the preamble, and it says exactly what it does on the screen, that guidance does not override the individual responsibility of healthcare physicians, healthcare professionals, that's us, to make decisions appropriate to the circumstance of the individual patient, in consultation with the patient, and or the patient's guardian or carer. So what this means is that as a clinician, we actually should, if we think it's necessary, override the guidelines. Now, I know what I'm saying is a little bit controversial, and I do get into a lot of arguments with insurance companies, and then usually I will quote them this guideline, this statement. Some guidelines do not contain this statement, but I think most good guidelines do, because they recognize that guidelines are guidelines, and they're not, you can't remotely control how a person, how a doctor treats a patient without actually examining the patient. So those of you who have attended my lectures before will know what's coming next when you see this chair. I'm a big advocate of something called clinical reasoning, which is because in the face of all these guidelines trying to control a physician and telling us what to do when you have not even seen the patient, I think we have to go back to basics as clinicians and do 4 important things. And these 4 things are actually articulated at the early days of evidence-based medicine. When evidence-based medicine was just starting out in the early 90s, it was always meant to be a balancing force to clinical experience. So the 4 things which are important are mechanistic reasoning. So we reason from first principles, why we do something, why we make a diagnosis the way we do. Next pillar is clinical experience. So the more cases you do, every case you do, you learn from. Every case you do should become 1 data point in your memory, right? So that you are able to fully appreciate, and you build up more and more data points with every patient you do. And so every case you do, you have to study from. The third thing is that what's available out there externally. And this is where the guidelines, the RCTs, and whatever you have out there, even if it's an uncontrolled trial, but if it's relevant to the exact situation you are facing, then it is important. So it gives you some more data points. The next point is actually the patients and your professional values. So this is a very important thing, and it was alluded to in the EULA guideline actually, that in consultation with patients, you will make decisions on how to treat. So these 4 pillars are like 4 legs of a chair, And if we only stand on the RCTs and the guidelines, you're only standing on one leg, all right? So you need to stand on 4 legs if possible, all right? And with that, I'm going to move forward. And a lot of times in the coming, the next part of my lecture, you will see where I come from with all these, with these 4 pillars. If you want to read further about this, go to the BMJ, go read the articles by David Sackett. And from there, you can, if you just look at the early 90s, this is what clinical evidence-based medicine was supposed to be. Unfortunately, it has become a method for big associations or bodies to try and control clinicians by telling us that we can only stand on one leg. All right, so let's move on. So if we talk about knee injections, I'm sure every one of you has probably done knee injections before. I'm not too sure who I'm speaking to, but I assume a lot of you are orthopedic surgeons and rehab or sports physicians. What I want to say about the hyaluronic acid injection is that the placement of the needle is absolutely essential for a successful injection. Now, this is unlike doing an injection with cortisone or lignocaine. Because if you wrongly place your cortisone or lignocaine needle, well, with lignocaine, nothing is going to happen. You might still get some pain relief. You may not get pain improvement, but if you place your needle with hyaluronic acid wrongly, you are probably going to get more pain. All right, so it is important where you place your needle. Extra synovial or extracapsular injections tend to be more painful. You tend to get these adverse reactions. And so here are some research studies which look at how accurate intra-articular injections of the knee are. They run from 71 to 93%. And in an osteoarthritic knee, the more severe the osteoarthritis is, it can go as low as 56%. Of all the approaches, and I'm sure you all have your favorite approach, the lateral patella, the lateral patella and lateral suprapatellar approach is shown to be the most accurate for general use. And ultrasound guidance does improve accuracy. Patients need to be comfortable and relaxed. If the muscles are tense, everything gets a bit harder. Okay. Now, so here's a picture of the, this is my favorite method, the lateral patella method, all right? And this picture here just outlines where I put the injection. You can feel for this space. So you feel for where the ITB is as it inserts. And there's usually a little hollow area here. You push the kneecap over, all right, a little bit. So that's what my hand here is doing. I'm pushing the kneecap laterally, and I insert my needle in. The angle of insertion usually is about 45 to about 60 odd degrees, all right? And you target actually to hit the center of the patella. Once you feel a give in the capsule and you start injecting, this is that you know you are in space. In case you're wondering, this is PRP, not hyaluronic acid. I just used the picture to show the technique. This is ultrasound-guided injection, right? So the only difference is that we go suprapatellar instead of lateral. We could go lateral as well. I don't have a picture to show it, but it's a little more difficult. So suprapatellar, we are looking for the space. This is the suprapatellar fat pad. That's the capsule. And if I play the movie, you can actually see the hyaluronic acid going in, right? So, so what you need to see when you do ultrasound, and you know 100% that the hyaluronic acid is flowing smoothly. Usually, as I inject, I will ask the patient, "Are you feeling pain?" And usually, if it's a good injection into space, they'll say there's no pain. All right, and there's no anesthetic inside the joint as well. So on the issue of anesthetic, what I would do is usually put a bit of anesthetic right here first, using a small 30 gauge half-inch needle just to inject superficially, and then I bring my needle through, and then I'll just tell them to brace themselves for a little bit of pain as I penetrate the capsule. Then we push through the capsule, and then once we are in space, we discharge, and there should be no pain, and there should be no resistance to your injection. All right. So if you're doing an ultrasound, you can actually see it flowing like that, very nice and smooth. Oops, sorry. Let's go to the next slide. Now, I also want to talk. So I'm going to leave the knee now, and because I've had some requests prior to this talk to talk more about shoulder and hip use, and I can't do that without talking about tendinopathy. And so, in case you didn't know, hyaluronic acid is being used for tendinopathy if you've been following the literature, but it's very much an off-label use. Here's a review which looks at 28 studies, and basically it was just about trying to see what the effects were on tendon studies. So a lot of these are preclinical animal studies. So hyaluronic acid permits better tendon gliding, it reduces adhesions, it creates a better tendon architectural organization, and limits inflammation. The short-term clinical studies are limited, but they are encouraging. There's no real good RCT at the moment. What does tendons do? What does hyaluronic do to the tendon cell? And this is the subject of this paper. It enhances the viability and proliferation. It counteracts the apoptosis, which is the cell death in the tendon-derived cells. And this part of it is actually not dependent on molecular weight, whereas the joint function is. Okay. So if we look at this study now, again, this is about 3 years old. This looked at the safety, right? Efficacy and safety. So this was a review of 71 tendinopathies. It was an open label clinical study, prospective, looking at various tendons, treated with ultrasound-guided peritendinous HA injections, given 3 times over every 3 weeks. That means once every 3 weeks. And there was significant pain relief and reduction in tendon thickness. So this is probably one of the most best studies you could find, but it's still a level 4, right? So we could say that the evidence is encouraging, not definitive. Based on rationalization and that limited evidence, we know that we should inject it peritendinous and not intratendinous. And I say this also because I had a patient who came to me from a neighboring country, actually, and he had received 2 intratendinous HAs for his tennis elbow, and both resulted in more pain. So do not give it intratendinous if you have time to do it. And therefore, if you're going peritendinous, it's better that you do it ultrasound guided, right? Because you need to be accurate. So let's go to the shoulder. So this is what I use the hyaluronic acid for on the shoulder. You could go with the, for osteoarthritis of the AC or the glenohumeral joint, yes. But an emerging thing of interest is actually for rotator cuff tendinopathy, where we give it either bursal or intra-articular. In some cases, I give it both. And another emerging use is frozen shoulder, where you may give it intra-articular or in the rotator interval. And this has not been subject of any study, but I'll explain more of that a bit later. All right, and I'll just present to you some rationalization. And then in bicipital tendinopathy, we give it peritendinous into the sheath of the long head of the biceps, usually under the tendon, in the bicipital groove. So here is a study which looks at peritendinous hyaluronic acid in patients with supraspinatus tendinopathy. And here it was subacromial hyaluronic acid injections combined with physical therapy. All right, so they have a high efficacy in the treatment of supraspinatus tendinopathy. And this was an RCT that led to an earlier return to pre-injury. Here's just some charts from that study. And so they found that you had a faster response than with physiotherapy alone. What about frozen shoulder? Use of hyaluronic acid. This is a systemic review. Used 7 clinical trials, 5 of which were RCT. And they found that using hyaluronic acid intra-articular had similar outcomes to cortisone injection. So right now, pretty much the standard of care at least for conservative care of frozen shoulder, is to shoot cortisone intra-articular. But there have been lots of interest in using something else, and hyaluronic acid is one of the other substances used. So it might be useful in the earlier stage in improving mobilization. Right? That's what this review found. Now, this just out of interest, I just want to highlight out there that people have compared hyaluronic acid with tramadol against hyaluronic acid alone, and they found an earlier pain relief with tramadol, short term but earlier. But I have not used tramadol. I think all these are little peripheral still, right? So they're a little bit too far out there. Now, what about intra-articular versus subacromial? So here's corticosteroid, all right, for treatment of frozen shoulder. And this was actually trying to compare whether it was more useful to shoot corticosteroid subacromial versus intra-articular. And they used and essentially 8 RCTs, 1 quasi-RCT, 512 shoulders, suggested that there was actually no difference. But as this study shows in 2 years ago, if you were to put corticosteroid injection into the rotator interval for early frozen shoulder, right, and this was an RCT, they showed that you could get an earlier improvement, and it was in this order. Rotator interval was the best result, intra-articular, and subacromial was the least effective. So taking the lessons from, so looking at steroid, that was a steroid study, but we know that steroids have deleterious effects. There are bad effects of steroids, which are listed here. And this is not a talk about steroids, but we all know that there are some bad effects of it. So, so the question is, what if we were to give hyaluronic acid at the rotator interval instead of steroid? All right, and this is still a bit of a question which is out there. I've started doing it, but I have not got enough experience to tell you how effective it is. I'll just show you in case for those who don't know where the rotator interval is, it's right down here. It is where the pulley of what we call the pulley of the biceps is. It is the point where the between the subscapularis and the supraspinatus on this side, where the long head of the biceps enters into the rotator cuff. All right. And if you do an ultrasound scan and you saw this image, because the theory is that with adhesive capsulitis, there's actually a kind of a constriction of this area, which results in a lot of inflammation. And this results in a lot of irritation to this area. And in theory, if you did an ultrasound assessment and it was very inflamed and you turn on the power Doppler of the ultrasound, you would see a lot of colored signals. All right. So this is with the patient in what they call a modified CRAS position, where your arm is put backwards at the back pocket of your jeans, right, at the trousers back pocket. So there's a way of identifying a very inflamed rotator interval, and when I see this nowadays in the frozen shoulder, this would be my target for hyaluronic acid. So let me just go back now into shoulder intra-articular injection technique. So most of us have injected the shoulder. We've all got our favorite way. Some like the posterior approach. It seems to be extremely popular. By palpation, it's supposedly quite easy to do. Anterior by palpation. Recently, a superior medial method has been described. I have not used this method because they have also described that it damages the superior labrum. And when you see patients with a superior labral injury, we don't want to further damage it. All right? We don't want to be accused of causing a superior labral injury. And for the subacromial bursa, we all have our favorite method. I like to use anterior or lateral. I like to use lateral the most. And again, by palpation or ultrasound guide. Rotator interval injection has to be by ultrasound. I think that's the best way to do it. And long head biceps tendon insertion as well. You need imaging guidance. The big thing is, I think there are some considerations when you do an injection. Asepsis, keep the field sterile. You decide on your approach to the joint beforehand. You choose your needle caliber and the length properly. And 21 gauge is what I usually use, or 23 gauge if I'm doing hyaluronic acid. So it's usually 23 if it's a small amount, but for most users, it's 21. If it's a very small area, I might even go down to 25. You have to decide whether you want local anesthetic on the chondral surface. I try to avoid that. I know many doctors who pump the knee with local anesthesia and then give the hyaluronic acid, and actually I don't think that's the best thing to do, because we know of the chondral toxicity of local anesthetics. So you know, on one hand we are trying to protect the cartilage, on the other hand we are damaging it. If there's a lot of excessive synovial fluid, you would try to aspirate some of that. Now here I emphasize the word excess, don't pull out everything, because if you dry out the knee too much or the joint too much, it actually becomes more painful. Okay, then accuracy, you should have no resistance. This is quite important. After the injection, you need to mobilize, and then you record the HA batch number, and usually I'll just say 24 hours of relative rest, where you are relatively sedentary. So intra-articular posterior by palpation, I'm just going to breeze through these. So many of you know this method. You go inferior and medial to the posterolateral corner of the acromion. You direct anteriorly towards the coracoid process, all right? And you feel, try and get into the joint space and feel no resistance. You can do this ultrasound guided. Similar, you just put your probe over the same area, and there are actually two ways to do it. You could do it in line, where you can see the needle, which is the red arrow in this case, or you can do it offline, where you can just see the disturbance of tissue and go straight in. So either way, usually this is done with the patient seated and the shoulder relaxed. Anterior approach, you would palpate. There are two different methods which have been described. One is to palpate the anterolateral corner of the acromion and coracoid and determine the midpoint, which is approximately 1 inch inferior to the AC joint. Or you can go 1 cm lateral to the coracoid, and then you direct it posterior and slightly superior. I'm sure many of you have tried this before. This is a newer method which was described in 2016, and supromedial. And this one, you can see from the pictures where it is, coracoid process, AC joint, and the lesser tubercle, and you would go in between. And so this is what this study showed, that it was, compared to anterior, it was actually more accurate. But you would have this problem of piercing the superior labrum, right? Now, what I do actually is an anterior approach, an ultrasound guided. This is actually my favorite approach, so I'm going to share it with you if you bear with me. So this is the shoulder. This is where we put the ultrasound head, all right? And this is the picture we will see with the coracoid process and the humeral head here, all right? We actually take the probe upwards superiorly towards the head, towards a cephaloid direction, and until we just see the coracoid just before it disappears from your view. And that's where you place the probe. And then the injection comes in here. So this is one of my patients, very recent, you can see, because he's actually wearing a mask. So it's during COVID times. Actually, it was just last week I took this picture. So here is the probe. This is the marking where I would inject. I would give a little bit of local anesthesia right here, superficially. Then I'll bring my needle in. So the needle would come in. We would give some more local anesthesia outside the capsule, and then we would dive in and go into the joint. And so I'm going to show you just a little bit of that. Now here you can see the needle coming in, right? And so this is an offline ultrasound, and you can't really see the whole needle. Later on, there'll be pictures where you can see the whole needle, but when I go, it's a simple technique to use, and you can see the needle actually by the amount of disturbance it gives the tissue, all right? And sometimes I deliberately shake the needle so that you can see it, all right? So this is going intra-articular, and once you're in there, the same rules apply. There should be no resistance and no pain. Okay, so what about the rotator interval? So again, here's the rotator interval. Subscapularis is here. Subscap is here, supraspinatus is there. All right, so here is the rotator interval, subscap, supraspinatus, and you would come in this way, and from lateral to medial, where this needle is, go into this gap. I don't have any of my own pictures to show, so I took this off radiology journal. All right. Biceps long head tendon is fairly similar. You would come in lateral to medial. So in this case, you can see fluid surrounding the biceps tendon long head. You can see some elevation of this bicipital, this ligament. You would just go into the sheath, not into the tendon, all right, to put the hyaluronic acid. And usually about 1 to 2 cc's can go in fairly easily. Right? Subacromial bursa, so I don't want to do too much detail of this. I'm sure you all do a lot of this. Anterior approach, lateral approach, right? And posterolateral. This is a study which looked at the efficacy of different routes, and the lateral is supposedly the most accurate route. And that's the route which I like to use, actually, because I do think it's the most accurate. And of course, you can put your ultrasound over it and do a guided injection in. So this is one of my patients with the ultrasound guided. You can see the needle going into the bursal area here, right? That's the needle, right? So you can see the needle as it comes in, and we're infiltrating the bursa, right? We're not intratendinous. Okay. What about the subcoracoid bursa? So this is an interesting one because I came across one patient recently, so if you look from the top, this is where the subcoracoid bursa is, and it's above the subscapularis, right? And normally it's rather small, but in some patients, when it's inflamed, it actually extends. And this is what you see in this patient. That's the coracoid process. That's the subcoracoid bursa. And this was a patient who had actually had calcific tendinosis of the subscapularis, and we cleared that using a procedure called 10x. But she ended up with a little bit of bursitis post-injection, and it was a bit painful. So we injected the bursa using hyaluronic acid, actually. Okay, so let's go down to the hip now. And the hip is a very interesting area. It's very challenging as well. And we know that viscosupplementation works for the hip. But again, the same rules apply. You must put it in the correct place. All right. So this is a systemic review and meta-analysis published in 2016, and they concluded it was the best conservative therapy before surgery, can act on pain relief and function. But there are only a few studies at that time. There's no evidence that it modifies the structure. Obviously, we don't expect hyaluronic acid to do any structural modification. Right? They concluded that the evidence that it influenced the natural history of the disease is also a bit limited. I think when we look at studies, we always look at them as data points. I always look at it as a data point, all right, and out of many possible data points. So we have this data point from 2016. Okay, now why did I talk about PRP all of a sudden? It's because in my own practice, I do use PRP for treatment of acetabular labral tear of the hip. Now, this is not a PRP lecture, so I'm not going to talk too much about this. But why I bring it up is because invariably in the older age group, when there's a labral tear and I use PRP, we also have to deal with a bit of an arthritic situation. So I quite often put PRP on the labrum and a bit intra-articular, and then I'll put hyaluronic acid intra-articular as well. And the other use I have for the hip is around the gluteus insertion at the gluteus medius and gluteus minimus insertion. This is very much parallel to the rotator cuff issues in the shoulder. So we put it around the tendon as well. I'm not going to talk about this very much. We're going to spend our time on osteoarthritis, right? Now, the hip injection the hip is a deep joint in most patients. Once you're obese, the hip is deep, but even in non-obese patients, you find some patients the hip is deep. So there are a few things which we need to be mindful of when we do a hip injection. Firstly, the hip is a congruent joint. By that, I mean that it is a perfect fit. The ball and the socket fit each other very nicely. There's not much space for other things inside there. Unlike the knee, which has all these undulations and there's a lot of space for fluid, the hip actually does not have much space for fluid. So whatever excessive fluid you put moves away from the head, moves away from the glenohumeral, the ball and socket joint, and it actually moves towards the neck where the capsule is more lax. All right. So the other thing is that there's something called the Zona Orbicularis in the head, and the other thing is to be mindful of the direction of the femoral neck. And with all this in mind, actually, in my mind, it's always best to be imaging guided when you do HA of the hip, either ultrasound or fluoroscopic. So here's what I was talking about. The Zona Orbicularis is the round portion, is where the fibers of the capsule go around the head of the hip, and they actually create a buttonhole type effect, all right, which actually prevents the hip from sliding through. And it's one of the mechanisms of stability of the hip. Now, there's actually a bit of variation of where the Zona Orbicularis is. It's important that your injection does not go below the Zona Orbicularis, it goes above it, all right, because below it, it gets nowhere, all right? So that's just the thing to bear in mind. The other thing to bear in mind is the direction of the neck, all right? And so the neck goes from a proximal to distal direction. It goes inferior, it goes downwards, it goes laterally, and it goes posteriorly, all right? It goes posteriorly, right, in this direction, right? So posterior direction. And the posterior direction can be quite variable depending on the amount of anteversion or retroversion. So just remember that it goes inferior, lateral, and posterior. Okay, now let's just go into non-ultrasound guided imaging, non-imaging guided injections of the hip. You know, if you have an ultrasound, use the ultrasound and guide it, right? But if you don't, you might be in a situation when you have to do this. And there's been some interest in this anterior approach. In the past, when many decades ago, we learned a lateral approach, and it turned out that that was about 50% of the time not hitting the target. And so, but this anterior approach was described in 2013. There was another study done here which used the same approach. And this study, the first one did 51 hips, and they verified the position by ultrasound. By ultrascopic surgery. So it was pre-surgically done. And then this other one used 161 hips, and they used symptom relief following injection as a measure for how successful it was. Both of these used lignocaine. All right, they used injectate, which is essentially a local anesthesia. Some of them use cortisone as well in some of their patients. So it seems to be quite successful, right, based on what we saw above there, right? Here's the one by Maidan in 2013 described. So what they do is they draw a vertical line from the medial side of the ASIS, and they draw a horizontal line about 1 centimeter distal to the tip of the greater trochanter, and where the two lines meet is where you would plunge your needle in vertically, all right, directly anterior to posterior, and you should hit this red point over here, right, which is the neck. So once you hit bone, you withdraw a couple of millimeters and you inject, and you should have no resistance. That's the method described. Now, this in the same year, actually, in another journal, this another method was described using anatomical surface landmarks, which claimed to be a little more accurate because it did not depend on 1 centimeter measurements and so on, which of course, depending on the size of the patient could put you in a different position. So in this one, what they did was they drew a line from the ASIS to the greater trochanter, and 1/3 way down this line, you would make a point and call it point A. And then you drew another line from the ASIS down towards the center of the patella. And so you draw that line, and then you draw a line here at right angles to this line. And where it bisects this line, you call it point B. All right, so from point A, this is where you put your needle in, and you hit towards point B at a 30-degree angle posteriorly. All right, so posterior, this angle here is about 30 degrees. All right, so this is the technique they described, and they did a verification based on a radiological study with the needle in place. They did the X-rays, they did the fluoroscopic, and they found that it was 95% putting the needle onto the neck of the femur. Now, I see the weakness of this as you don't know where the Zona Orbicularis is. All right. Both of these studies commented that the reasons for failure in non-guided hip injection was sometimes a high riding trochanter, variances in the femoral version, anteversion versus retroversion, In obese patients, you can't feel the landmark, so your accuracy goes off. And if you get variations in the ileum pathology, then you might be off. Now, so an important thing to remember is that in those non-guided studies, they use local anesthesia or corticosteroids. Now, what if, and they use them for diagnostic purposes to see whether an intra-articular injection would make some difference. And it was a diagnostic test to be done in the clinic. But we must remember that when we're doing HA for therapeutic reasons, we should try not to have that 5 to 7% failure rate, even with the best of non-imaging guided. And that's why I say that, if you have the ability to do imaging guided, do imaging guided, whether it's by fluoroscopy or by ultrasound, because if you are to inject wrongly, you would be causing more pain instead of having something neutral, like because if you are to inject cortisone and lignocaine, you inject wrongly, you don't really cause more pain, right? But if you inject hyaluronic acid wrongly, you cause more pain. And that's the reason why I always advocate for imaging guidance when we do hyaluronic acid. All right. Now here, so this is my method of doing ultrasound guided injection. It's quite a standard method, but with a little variation, and I'll tell you what it is. So you lie the patient down, supine, feel for the ASIS and the pubic tubercle, all right, and you sort of, so there's a line there. You bisect that line. You go 2 inches down, and you go 2 inches laterally, and that's where you place your probe. All right. Now, with this method, the good thing is that the modesty is preserved, right? Because the clothing of the patient, I usually tell them to just pull down your pants and pull up your underwear. All right. And we tape up the underwear here using micropore tape, and we tape down the pants. And all I need is this little triangle of space. And so we don't, the exposure is actually quite okay. Most patients do not feel shy with this, right? Because the only thing is that I tell them to come with briefs and don't come with boxer shorts and so on, which is hard to pull up. So come with your underwear should be briefs, which I can pull up very easily. All right, and then we tape it up. We put our sheets here, and we put the ultrasound there. All right, and then the injection comes directly under view with the ultrasound here. So here's a patient which I did recently. All right, so here's the ultrasound in position. The patient's head is at the top of the screen. This is his leg. So if you look at the exposure, it is very minimal. So here, we tape the sheets so they can, so that when I use iodine to clean, there's no staining of the person's clothes, right? So it's very minimal exposure, which we need to do the hip, right? Okay, so when we ultrasound the hip with the probe in that position, here's what we see. In this patient, you can see a little bit of an osteophyte. You can see some capsular thickening. The muscle layers are fine above it. This is what a normal muscle layer should look like, all right? And then if we extend the probe further down, you'll notice that, you see, this patient has a bit of osteoarthritis and a bit of effusion. And where's the effusion? It is all accumulating in this position. So this is what I mentioned earlier, that there's not much room for fluid in the joint. Excessive fluid just pools in this area. Now, if you attended ultrasound courses for giving injections into the hip, they all tell you to inject here, and all the ultrasound, all the palpation methods I presented earlier, this is their target. They go into this area. They don't go there. But over the years, I've been doing this for 15 years, and over the years, I've decided that it's better to go here. And I'll tell you why. Because number one, we don't know where the Zona Orbicularis is. Number two, we want to put the hyaluronic acid right in here. All right. And it's best to put it right in there. And the third reason is that, I bring in PRP again because a lot of times these patients have got lesions of the labrum, and I would use PRP on the labrum, bring in the needle in here, and then I'll push the needle all the way through into the joint, and then continue the intra-articular injection. So I personally prefer to put it here. It is actually easier to put it here. It's a little more difficult. But I think in the end, the results do speak, do have a bit of a difference. And this is my mechanistic reasoning and clinical experience, the first two legs of the chair, which I was told you about earlier, right? So And again, it's borne out by the patients whom you see recovering. This is just a sidebar. When we look at the ultrasounds of the hip, sometimes we can see the labrum actually tearing and displacing a little bit. Yeah? And I wanted to show you this because this is an example of a hyaluronic acid which was placed in the wrong position. This is extra-articular. All right, so this patient, she's 70-year-old. She has a hip osteoarthritis. She saw someone who did a HA injection into the hip, and she said it was more painful after the injection. And after that, she couldn't bend it properly, and she was in pain. And she came to see me, and we did a scan, and we found that there was this mass here outside the hip, and it obviously was an extra-articular injection of hyaluronic acid. And so I give it to her properly intra-articular, and actually the pain reduced a lot. So this really emphasizes the importance of getting your hyaluronic acid in the correct position. All right, so when we do the ultrasound, we also have the opportunity to do a measurement and see how far it is to the target area. In this case, it's 37.5 millimeters. In some patients, it can be about 5 millimeters, 6 millimeters in the more obese patients. And in some patients where they are really big and obese, you need to use a curved probe to see all the way in. Okay, so in most cases, we use a spinal needle. I usually use a 20 gauge needle. I would give local anesthetic at the point up here. Then I would track my needle in, give local anesthetic here, and then pause for about 10 seconds, let the anesthesia numb some of the nerves out here, and then push through the capsule and get into the intra-articular space. And I'll show you that in the next slide. All right, so here's the needle coming in. We are now, this is the extra-articular space. All right, and you can see me giving some local anesthesia right here. All right, so here's the local anesthesia. Then we pause a while. We actually give the local anesthesia every time we pass through a septal layer. So I didn't show you this part, but when the needle first comes in, you're watching it pump a little bit of anesthetic here, go through the septal layer. When you reach the next septal layer, pump a little bit of LA, go through the next septal layer, pause before the capsule, give local anesthesia, and then go in. All right, so this is going inside now. This is the intra-articular portion. And if you look, you can see a little bit of movement of the fluid inside the joint space here. All right. So that's intra-articular for the hip. I'm sorry, let's move on. Okay, now this part I sort of started doing in the last 3 years because I realized that this is why I was emphasizing the axis of the hip. And the hip being a congruent joint, we really want to get as much HA as possible into the joint space of the hip. And so immediately after injection, where I used to ask them to stand up and, okay, you're fine, we have injected, we put the plaster, you stand up and you can go and walk out of the room. Now I tell them to lie down for a while, and I put them into these positions. I put them into lateral recumbent first on the contralateral side. So this is the hip we injected. And because the hip, the neck, we don't want the hyaluronic acid in the neck. So we put them in this position, let gravity keep the hyaluronic acid up where the ball and socket is, and I get them to move their hip. All right, so I flex them, I extend them, I abduct them, I rotate them. All right, just move it passively for them, and they can do it themselves. Then let them do it themselves. And for about 5 minutes, they're just moving that every now and then. Then I flip them to a prone position, and I do the same thing because the axis of the hip is as it goes distal, it goes posterior. So we flip them anteriorly in order to keep the hyaluronic acid anterior. And there's no study on this again, but I can tell you based on my own experience that this does make a bit of difference to the success of your hip injection. If you get it intra-articular and you at least spend the first bit of time keeping the hyaluronic acid, letting it go and lubricate the head of the femur, it does make some difference. Because if you can imagine, I've come across people who told me that they did not have success with hyaluronic acid in osteoarthritis of the hip. And because if you inject it into the capsule at the neck of the femur and properly got the person to stand up, what will happen to the hyaluronic acid? It just sinks down into the neck. It sits at the lower half of the capsule, and it doesn't really go into the intra-articular portion. All right, so and that could be a reason why it doesn't work that well. So if you just make these little modifications, you might see a lot better success. Okay, so again, injection technique is a sterile field. Patient needs to be comfortable and relaxed. again, I emphasize this about 4 or 5 times now in this talk, that we need to place the needle accurately because the extrasynovial injections are more painful. And in the hip particularly, I would always use ultrasound because I have it in my clinic. But if you don't, and you're familiar with the fluoroscopic method, just use that. But bear in mind, immediately after injection, to put the patients in those positions. So plan the route, appropriate needle length. All right, so post-injection position and movement. And with that, that's my last slide. Thank you very much for your attention.
Thank you very much, Dr. Go. So we were paying attention to the questions and to the chat. So I will just. So normally we should have, yes, everyone on the screen. So we have some questions for you. So the first question would be, we have a question on, we had a lot of questions on that. Can we combine therapy of synolis with small amount of steroid? Is steroid, prilocaine or lidocaine possibility if they affect the efficacy of synolis? Even though Aptisen doesn't recommend it, we know that based on the physician experience, this is a procedure that is done or might be done. So Dr. Go, we wanted to know if you could share your experience on this question of steroids.
Yes, I think you can combine. I'm aware that there are products out there which already involve the combination of steroid with hyaluronic acid. Now, to me, the two are, you asked the questions, to me, you consider them separately. Do you really need the steroid? Why are you using the steroid? Is there a lot of inflammation to deal with? Or is that the main reason you want the steroid, right? So, because steroids, having the hyaluronic acid, I do not think mitigates against the bad effects of the steroid. Right. So I think the combination can be done in a situation where there's a lot of acute inflammation and you want to try and bring down the inflammation.
Thank you very much. So the next question would be if with PRP, if we do PRP first or synolis first. And here it's the same, even though Aptisen doesn't recommend it. We know that based on the physician. So we wanted to know if you could share your feedback on that.
I would usually put in the PRP first and the synolis, then followed by the hyaluronic acid, by the synolis. The reason for this is very simple, actually. Now, what we do know from PRP and HA combination is that there are actually studies which show that you do get the best of both worlds. HA, like synolis, tends to improve symptoms faster than PRP. Why do I go PRP first? Is because PRP is less viscous. And if you wanted to ensure that your needle was in the correct place, you go with a less viscous substance first, ensure that you have no resistance before you twist off the syringe and put on your hyaluronic acid syringe. All right. So that's what I've been doing. The main thing you have to ensure is you do not contaminate your field. Twist off, put it on. You are sterile gloved. Everything is sterile. All right. So you just need to make sure that you are not contaminating the field. So I've been doing this for about 12 years now, combining PRP with hyaluronic acid, or maybe 10 years. We've not had a single case of infection. So you could do the combination, but I would tend to do the PRP first, followed by the lubricant. The other thing you have to bear in mind is the total volume in the joint. So, the hip, for example, it's a bit pointless. I don't use, the hip is one joint where I don't use too high a volume because a lot of it just goes down in and accumulates in the inferior portion of the capsule where it's not very useful. So bear in mind, if you are putting two things, you will have more volume. So you need to plan what you want to put in.
Thank you very much. The next question is still for you, Dr. Go. Can you explain how HA helps in frozen shoulders, the mechanism of action that is involved?
Yes. Okay. No, I can't. That's a short answer. Okay. I think there are a few theories about, you know, in intra-articular, it's probably the lubrication effect. There could be a bit of volumization effect as well in a tight capsule. There could be a bit of an anti-inflammatory effect, but as far as I know, it is not very well explained. One study, I think I showed the study in my presentation, was that the effect clinically seemed to be the same as a corticosteroid, and based on the assumption that corticosteroids are more harmful for our joints compared to hyaluronic acid, doesn't it make sense that you use hyaluronic acid because you're going to do less harm, right? So that's the rationalization. And with regards to the rotator interval, I think it does make sense, because if it is, you're dealing with a constricted structure where you get frictional damage and frictional inflammation causing pain, then by lubricating the rotator interval, you might you might reduce the pain stimulus, right? You might get better movement of the biceps tendon through the rotator interval.
Thank you. The next question would be for both of you. Do you have any evidence to prove that Synolis is a better choice of HA for any inflammatory joint disease due to sorbitol effect?
Okay, maybe this one needs to be answered by Dr. Edward or, okay, but my own experience, I'll just tell my own experience first. I cannot say that positively it has, because my own experience with HAs is that there seems to be some prefer this and some prefer the other one, right? And the HA compared to, say, Synvisc is not as viscous as Synvisc has a very high molecular weight. So sometimes what you get with some of the other brands is that the patient comes off the couch and tells you, I feel like I'm bought a new pair of Nike Air or Asics Gel, you know, so immediately they feel that cushioning. But that can be very short-lived. Synolis tends to take a little bit longer to act. In terms of efficacy, I actually rate them fairly equal. But I must say I do like the Synolis 2 ml injection, because the width of the syringe is not very wide, right? And the resistance is not a lot on a 21 gauge needle. And this is important when you're trying to go intra-articular and feel for resistance. So my own experience is I usually tell patients that, okay, you may not get an immediate effect, but quite often about a week later, they do feel the benefit with Synolis. Now, compared to, so you're asking me to compare between the different ones I've used. I've used Synvisc, Monovisc, Synolis, some other brands, Hyalgan, and so on. The rest of it, I think, is very theoretical, and it's very hard to prove because we have the in vitro studies, which Berlina has shown that there is a better protection of the hyaluronic acid when you have sorbitol. So in theory, it should last longer, but it's very hard to translate that into symptoms. Dr. Edward?
To tell you the truth, you have just said everything.
Oh, thank you. Okay, so let's move on to the last question, I think. Dr. Go, in your experience, is Synolis VA 2 ml 40 milligram enough for an OA need grade 2-3?
Well, one jab is not enough. I go between a total of 4 ml to about even 8 ml to 10 ml in some of the bigger patients. Not in one shot, of course. You don't do 10 ml in one shot. I can do 4 to 6 ml in one shot, depending on the size of the patient. The average patient, let's say a 5'10" male, weighing about 75 kilos, I might do about 4 ml if I wanted to do it as a single shot. Otherwise, we are actually, I mean, the original packaging was 2 mLs, and traditionally in HA, we usually go 2 ml, 2 ml, 2 ml. Now, let me tell you something. I have a theory on this, and I don't know whether Dr. Edward, who's gone into the history of HA, can give more light on this. But in the early days of HA, before we had guidance, and people were just doing blind injections, and you would get a percentage of patients who had pain after the injection. I suspect a lot of it was because of a misplaced needle, right? And you can tell because when you inject a patient and he says it's painful and you tell him never mind, in Malay you say tahan tahan, you know, and you keep going with it, you are actually injecting into a fat pad or into a synovial space, synovial membrane, and you may not be injecting into synovial space. And you imagine that if you are trying to inject 4 ml into a fat pad as opposed to 2 ml, it would be extremely painful. So I think in retrospect, it was a wise decision in the early days to always have 2 ml preparations, because you could do less harm if you injected in the wrong spot. That's my take on it. And I think those who are less experienced at injecting should stick to the 2 ml and do repeat injections. That's my own take also, because unless you're really confident, and you could always convert a 2 ml to a 4 ml. So if you start with a 2 ml, you go into the joint space, you're very confident, you ask the patient, is there pain? And he says there's no pain, and you feel a nice smooth action with no resistance, then you can just tell your nurse, get the other 2 ml, and you just twist off the syringe, put the other 2 ml on and continue. And let me tell you, I do that very often, you know, sometimes, because if I'm very sure I'm spaced and you save the patient one trip and another injection, why not? See, then you just deliver all 4 ml in one shot. My own take is that I think there's not much difference between delivering 2 ml this week and 1 next week versus giving all 4 ml this week.
Exactly. Well, there is one aspect also which is fairly visible. I completely agree with Dr. Go. Which was fairly visible also retrospectively and historically from the first studies that have been published. The dropout rates from the study, the dropout rate at the early ones, especially after the week 1 and the day 30, were significantly higher in the beginning, where people were still making more mistakes, and the number of swelling, pain, and associated as a side effect associated with the intra-articular, these were specifically knee injections, have been systematically reducing with the time. So the main cause of that was simply missing the target, the positioning of the needle, especially in a large multicentric studies that happened often. So yes, I would completely agree with Dr. Go that it is better to be careful, start prudently, go with a lesser volume, and then decide upon eventual extension, be it immediately in the office or 1 week later. And also what one has to mind is the size of the articulation. You know, the question between a little lady, the elderly, and a basketball player. The size of the knee is not comparable. So that is also one decision-making factor.
Yes, I agree.
Okay, thank you very much. So we answered some questions directly on the chat. If there are any further questions, I think that now we are running a bit late, and we should finish, I think, the session. If there are further questions, don't hesitate to send us an email. I put the email address on the chat. Thank you very much, Dr. Go, Dr. Vidovic. And I hope that you all like the session. Don't hesitate to give us a feedback. We will send you out a small questionnaire, and have a very nice afternoon.
Thank you.
Thank you.
Bye, everybody.
Thank you all. Thank you for
Bye. Thank you.
Bye.